Let's talk about anxiety disorders, much more common with diagnoses. Okay, so it anxiety disorders are related to fear, and the fear can be real or perceived, right? A lot of people with anxiety know that sometimes they have irrational fears, okay? Um, but they also can't really help it when their nervous system is responding to whatever their environment that's saying maybe it's a threat, right? That's a threat. And what we really notice in the field is how powerful our thoughts are, right? Because it can start with a thought and then it manifests. By the way, if you hear that noise, it is my snoring dog. She's like 10 pounds and she snores. She might have apnea, but for now, dogs don't wear CPAPs, okay? We're not going to get anxiety about it, right? We're just going to do the best we can. So anxiety is usually future based. This is really interesting. I tell clients a lot of times when you're traveling to the future, it's the what ifs, right? Well, what if this happens? Well, what if, but all we have is right now. But when you have anxiety, it's really hard not to do that because for a lot of us, our nervous system has learned to adapt to its environment by anticipating future events. So, generalized anxiety disorder is probably the most commonly diagnosed um, in the anxiety realm. If people are coming in presenting with anxiety, and this is characterized by a global persistent feeling of anxiety. I will show you the criteria to help you understand. Just to simplify this, you see it's very common with somebody with generalized anxiety. They have anxiety about their anxiety, as in maybe they feel anxious, but they're not really sure, so they start to get anxiety about that. A lot of times that resonates with people when I share it in that way. It's about 3 to 6% of individuals that experience generalized anxiety at some point in their lives. Okay, so it's not uncommon. It's very common. It depends on different times in people's life, etc. Females are twice as likely, so female assigned at birth are more likely to be diagnosed than males. Why is that? Like use kind of your critical thinking, right? Is women, females assigned at birth may be more likely to seek treatment, maybe more willing to be honest and open about their worried, anxious feelings, where assigned males at birth may kind of normalize, oh, this is just what you do, right? And there is a high correlation or comorbidity with anxiety disorders and things like depressive disorders. There's also a comorbidity with like anxiety and maybe alcohol use. Maybe people are kind of coping with alcohol use with cannabis um, to sort of treat their anxiety. The problem is a lot of times, like with alcohol, that can increase your anxiety, right? If it disrupts your sleep, that can increase your anxiety. And so, there is comorbidity with anxiety and other diagnoses. Mhm. Okay, so remember when I talked about assessment? So meeting the criteria. So features of it could include the following: excessive anxiety and worry, um, occurring more days than not. Remember, I said timeline is important. Occurring more days than not for at least 6 months about a number of events or activities. It could be school performance, work performance. The individual finds it difficult to control the worry. Usually, people with anxiety, if somebody says, well, just don't feel anxious, right? Oh, I didn't think of that. Like, of course, you've thought of that. But the person with anxiety, it's not something they can control. We'll talk more about that with the treatment plan too, of maybe how to navigate that. The anxiety and worry are associated with at least three or more of the following symptoms, with at least some symptoms present for more days than not for the past 6 months. So that's a timeline. You can meet some of the criteria, but to have a full diagnosis, you do have to meet, the criteria. So at least three of these things. restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or your mind just going blank, irritability, muscle tension. So maybe you feel it in, your neck or you're having jaw is another one. TMJ can be related, not all the time to anxiety, but you're like tensing your muscles and you don't even know it. Or sleep disturbance. You do have to have at least three of those more days present than not for the past 6 months. Okay, the anxiety, worry, or physical symptoms cause clinically significant distress. It's causing distress in your life, your relationships, work, social, occupational, or other areas of functioning. Usually, when people come to therapy to talk about these things, they are usually in some sort of distress. This is the distressing event that's having them look outside of themselves to get help, which is a beautiful thing. It's amazing. It's not fun when you're first in it, right? But this is usually because it's like, I can't do this anymore. I need help, which is a beautiful thing. I commend people when they first come to me saying that. The disturbance is not due to the direct physiological effects of a substance such as like a drug of abuse or a medication, because that's going to be the primary diagnosis, right? The anxiety may come secondary, but we really need to address in treatment the substance abuse, right? Because think about it, if you reduce the alcohol use or the drug abuse, and the anxiety may just naturally go down because it's secondary, right? And so, what came first, the chicken or the egg? Hey, sometimes hand in hand, people may have issues with alcohol and they're having anxiety. If they start to reduce their alcohol use, they may see that maybe their anxiety symptoms. It doesn't mean it's a cure-all, right? But they may start to say, hey, this is like risk reward. I really need to weigh the pros and cons. Um, or it cannot be a general medical condition that's not better explained by another mental disorder. Okay. So selective serotonin reuptake inhibitors, say that 10 times, right? Or SNRIs, it just touches base on a different neurotransmitter. Serotonin norepinephrine reuptake inhibitors. So SSRIs common like Lexapro, Prozac. There's lots of other names, right? Those are the two that are coming up. SNRI is something like Wellbutrin. SSRIs touch on the serotonergic neurotransmitter or the norepinephrine neurotransmitter, just different mechanisms. And so that has been shown high efficacy with anxiety. 30 to 50% of positive responsive rates. But here's the thing is the psychopharmacology, taking a medication helps, but it does not necessarily help after discontinuation, right? So it's helping your brain, but this is where therapy can really come in and help, where in therapy it can teach you new skills to help you. So sometimes you do need medication to stabilize your nervous system, okay? It doesn't mean you're weak. You may need that to get back to homeostasis so that you can function. Then in therapy, that's when we really need to look at like REBT therapy, Albert Ellis, rational emotive therapy, is really about your beliefs about something. Okay, because you heard me say earlier, your thoughts can really be tied to your behaviors, to the consequences of that. And so, Albert Ellis really taught what is your belief about it, and can we like almost like retrain that belief? Here's the thing. So what can be learned can be unlearned. So Albert Ellis really taught with rational emotive therapy of let's look at the situation differently. Okay. And what is your belief about it? Because a lot of times we don't even realize consciously that we're holding on to a belief of, like I said, you're not weak if you take medication. People may think, well, that just makes me weak because I have anxiety, right? That's a belief. We have to explore where that belief came from. Is that really true? And so these things can help people really start to learn new tools to then take those things that we teach in therapy and utilize those on a daily basis. I sort of live in people's hippocampus of their brain working with them, and they'll be like, I pictured like, okay, what would Carrie say to me right now? Which is a beautiful thing because I'm almost helping them with that internal voice, right? To get them to look at a situation differently. So it's learning to replace those negative thoughts to help with anxiety and depression and changing your belief about it. It takes time. You don't go to the gym and you get a six pack right away. Okay. That would be amazing, right? We would all do it. But it takes time to build muscle. It takes discipline. The same is true for changing our thoughts, especially if we've had the same belief system for so long, we didn't even realize we had a distorted belief system. Cognitive behavioral therapy is another one where 60% of individuals report a reduction in anxious thoughts 1 year after treatment. So our rational emotive therapy and cognitive behavioral therapy can almost be thought of one and the same. They're not, right? We want to give credit where credit's due. Albert Ellis believed that the core idea is it's not events that disturb us, but really our beliefs about them, sometimes even irrational beliefs. A lot of times we don't realize consciously that we have an irrational belief about something. And so a lot of times what I'll ask clients is, well, if they're having like anxiety or fear, I'll say, well, what do you think is the worst thing that could happen? That alone gets them to start thinking, well, what is my deepest fear about this? Well, my deepest fear is that I'm going to be a failure. Oh, okay. So, what would make you a failure? Like, where have you felt like a failure? And this is where they start to deconstruct their beliefs and say, well, wait a second. Okay, well, how are you feeling, now that we've talked about it? Well, I don't feel as anxious about it. I feel like I was able to say what my deepest fear. It's almost like it no longer keeps it like in control, that thought or that belief. It sort of lets some air out of the balloon, so to speak, by talking about it. Doesn't mean it's a cure-all end-all right away, right? Cognitive behavioral therapy, it's identifying and restructuring. So automatic thoughts, right? Knee-jerk reaction. So maybe and that might be something you do if you're more cognitive. Well, what thought did you have about that? Maybe not a belief. What thought? Well, I'm a failure. Okay, that you're a failure. What evidence do you have that you're a failure? So let's say they got anxiety, they failed a test. I'm a failure. That's the thought that they had, right? Okay, so you failed a test. So like help me understand what evidence do you have. Well, this test. So that one test reflects who you are and the entirety of your life? Like, do you hear the irrational thought about that? That, like, whoa, let's look at this in a different way, right? Let's look at a more realistic way. Like, why do you think you failed the test? Let's take accountability because here's the thing is the beautiful part is if we're the problem, that's a good thing because we can fix that, right? Because we can look at ourselves. And so maybe you failed because you've been so stressed and you haven't really been learning to balance time and um, you've been people pleasing and you haven't been saying no to people. Hey, like I really honor that part of you that that is owning that right now. Okay, so does that make you a failure or does that mean that you maybe failed to say no more? And can you add that? That way, we're almost deconstructing these thoughts that become like matter of fact, right? Similar to the beliefs, we're trying to take those beliefs and really kind of look at it a different way and say, well, when you believe that, what is the consequence of that? And how could we maybe change that belief? Okay, it's just kind of to me, it's a little bit of play on words. I use them interchangeably, and I just kind of use it intuitively depending on which client is going to benefit from it. Sometimes I sprinkle a little cognitive behavioral rational emotive therapy, even with somebody who's not necessarily having anxiety, but for anxiety, it can be really help to have you kind of slow down and walk yourself through these things. Biofeedback is another really great one. I shared a link into biofeedback so you can learn more about that. And that's really learning to be in tune somatically with your body and recognize when your body's giving you cues. Remember, our thoughts are powerful. And so our thoughts can really start to um, increase our anxiety, right? And so if we can learn that we have some control over that in our bodies and maybe start with our bodies, we can actually have better control of how our nervous system responds, right? And that's part of the practice as well. It's building a muscle. Super interesting. I love it. Okay, specific phobias are when a person experiences anxiety related to a specific object or subject, right? So this is where a phobia is kind of narrowed in with anxiety in one specific thing, right? So, and people typically try to avoid that object or thing, whatever it is. We'll talk about um, you think of people like who maybe had a negative experience with a dog and now they have a phobia of dogs, right? And so it's a specific anxiety related to, an object, subject. Nearly 75% of individuals report fear in more than one object. Okay, just something to make note of. Their nervous system may automatically be heightened, and so it's not just one thing. Let's see, prevalence is about 7 to 9% in the US. Let's see, 5%. Let's see. 7 to 9% among children, 7 to 9% overall in the US. I'm like, wait, I'm getting confused. Among children, 5%, and then teens, 16%. Females are twice as likely to be diagnosed. Again, maybe more likely to seek treatment. We are seeing a shift in that. Children and adolescents who are diagnosed with a specific phobia are at increased risk for additional psychopathology later in life. Okay, this doesn't mean that it's for sure a cause and effect, right? But this is very telling. This is saying, yeah, if children have heightened anxiety about a specific phobia, they could also have a misdiagnosis and had general anxiety that maybe was what wasn't found in childhood, right? And so it's not to say that if you had a phobia as a child, you're going to have psychopathology later in life. There just is some correlation with that. Okay. Okay, so to meet a specific phobia, remember the criteria. It has to include the following: marked fear or anxiety about a specific object lasting 6 months or more. Now, some of these will be 6 months, some of them will be 2 weeks. You really, as clinicians, we have to look at how long it's been going on. The phobic object or situation almost always provokes immediate fear or anxiety and is avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual danger posed by the specific object or situation. So if you've seen somebody with a phobia, for you, it may feel really irrational because their heightened response, it's like their fight or flight response is completely triggered. And it might be this little tiny spider, or it might be, this bee, and people might have this really heightened response. And so to somebody that's not triggered by that, it feels out of proportion. But for them, it's very, very real. That's how you know it's like a phobia for them, right? So the fear, anxiety, or avoidance of something, like if somebody's afraid of like bridges, they avoid all bridges, or they're afraid of the freeway, so they have and avoid the freeway entirely, which is going to limit them, right? It causes clinically significant distress or impairment in social, occupational, or other areas of functioning. You're going to see that over and over with the DSM criteria. There's always this, is it causing distress in their life? Okay, because that's a big factor. The disturbance finally is not better explained by symptoms of another mental disorder. So, you really want to look as a clinician for generalized anxiety disorder. This may be sort of, somebody may have a phobia and generalized anxiety. This is why I think they talked about psychopathology later on in life, because somebody may already have a heightened nervous system growing up in a traumatic, you know, with a traumatic upbringing. Their nervous system already responds to their environment in a different way. Okay, so exposure therapy, very, very high efficacy. Because if you can desensitize yourself by being exposed to that, um, you have new neural pathways that connect to that experience to reteach you or you relearn in a new way. So if you're afraid of bridges, building up the strength to face that bridge, right? That can really help you desensitize, and maybe you have a more positive experience. So now your brain doesn't say danger, danger, danger. It sees it as like, you are so brave. You were able to overcome this. A lot of times people will say if you have a phobia, you just have to do whatever you're afraid of. And then, you'll no longer have that. Maybe. I think what they're talking about is systematic desensitization, but systematic means it's a system. It's it's gradually working your way up there, okay? So it's going to teach you relaxation strategies, which are going to help you anyways, because you're telling your nervous system to calm. You know what I mean? Like, you are safe right now, you're calm. Um, and then while you learn those skills, then you're presented with a fearful object. Um, based on this fear hierarchy. So you're going to work through this hierarchy to really get them to have new neural pathways and reconnection of that. Um, I wish I could say it works 100% of the time, but a lot of people may, avoid. There may be flooding where the person has like this out of proportion fear and they literally avoid it entirely and maybe don't even go into therapy anymore, right? We don't necessarily leave like the office to do systematic desensitization all of the time. But this can be something that have clients work towards. And so if you don't want to flood somebody's system, right? Because if they go into full panic, by you just exposing them or throwing them into this phobia, like people suggest, um, there's a greater risk for dropping out of treatment, right? Because now they have this new traumatic event that they associate. Now therapy equals flooding my system, danger, danger, danger. In modeling, the clinician can approach the feared object or subject while the patient observes. So they see you, let's say the person's afraid of dogs. The clinician is really kind of modeling this appropriate behavior and really kind of subtly showing them, hey, I can maintain calmness. And that can sort of help as like scaffolding and support. So there's something called in vivo exposure. So that's in person or even just imagining it. I would say, energetically, even just having your practice use it, having your clients practice using their imagination, then you can go to like, hey, on a scale of, 0 to 10, how are you feeling right now that you're imagining this, right? And then really get them to feel empowerment. And then maybe as a goal of this in vivo exposure and meeting them at a place where they can see a dog, right? And then having a new experience. So, agoraphobia is an individual experiences fear of leaving their home or traveling to public places. Again, I want you to go through the criteria that you see. It needs to include those things. Let's see on the time. The fear, anxiety number, I'm sorry, letter F. The fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. You see a lot of those 6 months or more. There are other times, but that's really important. Oh, look at the other one. G. Fear, anxiety, or avoidance causes clinically significant distress. There it is again. Okay. So, an individual must present with fear every time in at least two of the following situations: public transportation of some sort, large open spaces, enclosed spaces, large crowds, or being outside the home in general. This tends to avoid, um, it causes avoidance behaviors. And so the person, you may see really extreme cases where the person hasn't left their house in years. They won't even go to the mailbox because that doesn't even feel safe. Um, and so, we're not talking about just not liking to leave the house or be around large crowds. Remember, letter G, it's causing distress in your life. You can't go to your child's graduation because it's a large crowd and you just can't handle that. That's going to cause distress, right? You can't go to your child's wedding because the anxiety that you're having about all the people being there. Okay. So typically we see agoraphobia develop later in adolescence, early adulthood. Um, it can be comorbid with other anxiety disorders, depression, which makes sense, and or substance use disorders. Those are the kind of common comorbid diagnoses that we see. We also see a high comorbidity between post-traumatic stress disorder and agoraphobia, but that's usually because the person had really traumatic event where they thought that they were going to lose their life or somebody close to them lose their life. And so crowds may trigger that nervous system response. So exposure techniques are most effective. Um, let's see. If present with panic disorder, uh, cognitive behavioral and exposure. So remember, cognitive behavioral is what evidence do you have, and really getting them to practice reframing it, looking at it in a different way, finding a more balanced thoughts, right? So being more mindful of our thoughts, not necessarily controlling our thoughts, but don't let that thought win. We sort of take that thought and we look at it and we try to reframe it to say, hey, let's look at this in a different way. And with in vivo exposure can be really, really effective. Okay. So without panic disorder, individuals typically benefit from group therapy. So being around others so they don't feel alone. Okay, social anxiety disorder is when an individual experiences out of proportion levels of anxiety related to social or performance situation, where there's a possibility that they will be evaluated negatively. This is interesting. There's a higher prevalence in the United States than in other countries. Things that make you go, right? I wonder why that is. Is it like performance? Does it feel like judgment? Um, all right. Oh, good. There's the criteria. Okay, so criteria, remember, somebody can, because a lot of times people will use this term loosely. And so I just want to emphasize that it's important that somebody meets the criteria, right? So it includes the following: marked fear or anxiety about one or more social situations where the person is exposed to possible scrutiny, judgment, right? With the fear that one will act in a way or show anxiety symptoms that will be negatively evaluated. So it's almost like you feel like you're going to be exposed. The social situations almost always provoke fear or anxiety and are avoided or endured with intense fear or anxiety. So it's a lot of times that those thoughts that they have about it. The fear or anxiety is out of proportion to the actual threat posed by the social situation. So maybe it's like, oh, these are going to be your friends that you've known since kindergarten, and the person is still having this real huge fear about being exposed and being judged. The fear anxiety is typically lasting 6 months or more, causing clinical distress. And then the fear, anxiety, or avoidance is not attributable to the effects of a substance or another medical condition, and it's not better explained by symptoms of another mental health disorder or condition. Um, and then the DSM does want you to specify if it's performance only. Is the fear restricted to like public speaking or performing in public, right? Which is a high phobia. A lot of people do have public speaking phobia, right? But social anxiety is kind of more, it's broader, where like social public speaking, you can avoid taking public speaking, right? Or just avoid speaking in general to the public. Social anxiety is now it might be causing distress because now you're avoiding all social relationships. Again, exposure therapy is one of the most effective treatments. It's again kind of retraining your brain to say, like, hey, you can do this, like slowly systematic desensitization, social skills training, um, cognitive restructuring. So again, that thinking, your thoughts about it. Usually people's number one with public speaking in classes, I've had students do public speaking. I'm like, what is your biggest fear? What's the worst thing that could happen? And usually what people say is that I'm going to be judged. And that makes sense. We have a need to belong, right? We're afraid of being judged. But let's think of it in like reality, right? Do we think we're going to be judged because we said a word bad or wrong? Like, are we really? Think of those thoughts going back to rational emotive and cognitive behavioral. Your belief is that what? Then somebody's going to think I'm stupid if I mess up a word. We all mess up words. Sometimes I don't get proper sleep and I don't say words right. Sometimes I can't remember the name of words. That doesn't make somebody's intelligence, right? That doesn't make somebody stupid. And so, if we can learn to see it in a different way, hey, I'm afraid of public speaking. I am afraid of it. But here's the reality most people, especially the other students, are probably more worried about how they're going to do on their performance of the public speech. They're not even maybe thinking about you and the word that you messed up. I mean, I know it feels like they might be. And this is where somebody with social anxiety has this like out of portion response to it. Maybe they had a real experience, and that's where some of this comes from, right? So we don't want to dismiss or minimize. We want to say, oh my gosh, that makes so much sense. You really experienced that, and you're afraid that's going to continue to occur. But here's the thing, what can be learned can be unlearned. So that's what this restructuring is sort of doing is let's practice this so you can have new experiences and have a corrective experience with it. Okay, panic disorder is when an individual experiences unexpected panic attacks, a sudden, abrupt surge of fear or impending doom. It can be diagnosed with agoraphobia. It usually doesn't develop until about age 14, or maybe that's when it sort of presents itself. It's rarely an isolated disorder. So usually there is comorbidity. It can be other medical symptoms as well. And so if you've ever had panic, a panic attack, panic disorder, I have had two in my life, did not forget those. And you do have physiological symptoms. You get dizziness. Um, what's really interesting is now looking back, the thought that I had is, oh my gosh, something's wrong with me. And then your heart starts to beat. A lot of people will go to the emergency room complaining that they are afraid they're having a heart attack. That does not mean that they're not having these physiological symptoms, but they feel so real when you're having them that it's almost unbelievable when you go to the hospital or the doctors and they like run the EKG, an assessment, and they say your heart's great. We think maybe it's anxiety. A lot of people can't believe it because let me tell you, the two that I've had, and I won't forget them, they're so debilitating. and I don't want to minimize and be like, that's all that it was, but it feels so real in that moment that that's what it feels like is that's all that it is, which I'm not, again, minimizing, but you feel like you are literally not going to make it out, right? That you feel like you might be dying. And then what happened to me is once I had that thought, going back to cognitive behavioral, I just spiraled from there. Everything was moving dizzy for me. I started to say, I'm going to be like this forever. And then let me just tell you, I was actually in grad school when I had my first one. And I literally thought, let me look up the symptoms of a panic attack. Let me tell you, when I read it, it grounded me. It's not like it went away entirely, but I thought, okay, I think there's a name for it, right? And so what it did is like instead of spiraling, it helped me have handlebars. So it wasn't like I was riding a bike without the handlebars. It gave me handlebars to say, hey, I think this is what it is. And that actually helped me to get grounded again. All right. So I told you it's very debilitating. You have four or more of the following symptoms: palpitations, pounding heart, sweating, maybe sweaty palms, trembling or shaking. You might have sensations of shortness of breath or feeling smothered or something on your chest, feeling of choking, chest pain, discomfort. Remember, I said a lot of people go to the emergency room for that. A lot of times people will complain of somatic symptoms. That's why it feels so real. But remember, our thoughts and our beliefs are so powerful that they actually, our body responds to it. Um, and once we start to kind of get that and learn grounding tools, right, and cognitive behavioral, um, we can actually start to check in with our body and then recognize, okay, like I said, once I realized what I was having, the symptoms sort of started to dissipate. Nausea, feeling dizzy, chills, heat sensations, parathias, wait, para, parasithius, parasithius, parasithius. I think I'm saying that right. See, like I just talked about public speaking and the word, and then it happened later on. That word. Numbness or tingling sensations. That'll freak somebody out, right? The left side of you goes numb. And these you're really having these physiological reactions because you're panicking, right? This is why it is panic disorder because it may have started for me of, oh no, something's wrong with me. And then from there, it like spiraled and my body started to respond to that. Derealization or depersonalization. So that's disassociating. So you can feel unreal. It feels like I just don't feel like myself. It feels out of body, or being detached from yourself, like losing sense of time. You can have a fear of losing control or that you're going crazy or a fear of dying, right? And let me just tell you, when I had mine, I feel like I had all of these. And so, um, it makes sense. It's really debilitating. Okay, that was panic attack. Panic disorder. Okay. This doesn't say panic attack. That doesn't say a time though. Remember how I was saying like the 6 months? Panic disorder is recurrent unexpected panic attacks, like we just talked about, that are present. So you can't really control it. At least one of the attacks has been followed by 1 month, there we go with the time, or more of one or both of the following: persistent concern or worry about additional panic attacks or their consequences. This happens a lot. If somebody has a panic attack in like the store, they have this worry that it's going to happen again, especially if they go back to that store or a store, right? This is where they start to associate that. A significant maladaptive change in behavior related to the attacks. For instance, avoiding the store. Let's say it's a grocery store. You have to be able to go to the grocery store. And then the disturbance is not attributable to the physiological effects of a substance, so drug use or medication, or another medical condition that is not better explained. And so that's where somebody can get a panic disorder diagnosis. So you can have a panic attack like the two that I shared uh, without meeting the criteria for panic disorder. So if I continued to maybe avoid the store, or maybe I dropped out of school because I had it in grad school, right? Then it's going to cause distress in my life. Let's say I go into therapy, I start to describe this to the clinician. They're going to probably start to conceptualize and say, this is sounding a lot like panic disorder. Let me go into the criteria and see if that's what we're kind of looking at. And by the way, going back to assessment, this can also, if, since it's an ongoing assessment process, you can always say, hey, I just want to like check in with you. Have you changed anything recently? Because remember, it's ongoing. So maybe they started to take a medication and they don't realize that one of the symptoms is heightened nervous system or sympathetic nervous system. And so you always want to kind of assess and look at these things. Has something changed recently? So cognitive behavioral treatment is really, really effective. Psychoeducation, again, it's just kind of talking about the nervous system. Biofeedback can also be really helpful because then you start to see how your body responds and you feel like you have some control. This is a part of self-monitoring. Maybe you keep a journal. Relaxation techniques, mindfulness. This includes progressive muscle relaxation. So, where you tense up and then you let loose, and then you tense up your shoulders and you let loose. You're almost telling your body you can let go, you can relax. Cognitive thinking, restructuring, exposure, right? It really, like if you became afraid of the store, maybe we're going to work our way up to exposing and going into the store again so that you can, tell your nervous system, hey, we're safe, we can do this, right? You want to build up to it, not flood the system. And then, yes, pharmacological interventions. So, medications can help bring homeostasis. But remember, a lot of those medications that bring you to homeostasis don't really get to the root of the problem and have you practice these techniques, right? So, for instance, as an example, the GLP-1 medication that people take to help lose weight, right? Well, that is great if it helps, especially with diabetes, and that's where it's especially with type 2 diabetes, I should say. But the thing is, if somebody stops taking that, if they have not dealt with their relationship or unhealthy relationship with food and the associations with food, they may regress back and gain weight, right? The same is true for treatments. Psychopharmacology or pharmacological interventions can help bring homeostasis so your body you can feel safe, but really the other work is, hey, let's figure out what's going on and help you feel empowered that you can do anything you put your mind to and you can learn new skills. Like someone going to the gym, right? So maybe they're taking GLP-1 and then they're going to the gym. Well, they're creating this new lifestyle and this holistic approach of I'm going to take care of my body. Does that make sense? And so that's why it's important that we talk about kind of this whole picture. All right. So there are biological, if you actually talk to family members, you will probably start to notice if you can identify anxiety in yourself that there are family members. This may be something that shows there are biological factors. So associations, experiences that we've had, um, classical conditioning, so things, that we learned, that we associate. Sometimes we don't even remember. poor little Albert, they exposed him to a rat and they put a bell next to it and they rang a bell and that scared the living crap out of little Albert, right? And so then what they did is they scared him and then they put a rat by, right? And so little Albert sees this and he's curious with the rat. Well, now he associates seeing the rat with danger, danger, right? Now his nervous system is like, oh my gosh. So he doesn't even have to hear the loud noise. As soon as he sees the rat, he gets frightened by it, right? And so now he's associated, and then he might generalize it to all furry things he's scared of. And so little Albert needs to be desensitized and re-exposed gradually to this to say, hey, like our rats are our friends. And it was pretty jacked up that they had a loud noise to scare little Albert. Poor little Albert. All right. Hopefully that helps.